Good afternoon, my dear students. I hope you all are fine. Today we will be discussing a very important topic in periodontology, furcation and its treatment. Maybe in your book it is given furcation involvement and its treatment. So please write the topic. Now, before we go into the topic proper, let's go to the learning objectives. At the end of the class, you should be able to, number one, define and classify furcation involvement. Number two, causes of furcation involvement, which is not given in the slide. Number three, enumeration of various factors that affect furcation involvement. The fourth and the last, outline the treatment for various classes of furcation involvement. Now we will cover this topic this way. First we will define it. Then we will talk about little bit about its causes, etiology of furcation involvement, classifications, different classifications we have. So we will cover almost all the classifications, important ones. Then we will talk about anatomical factors affecting furcation involvement. And then finally the treatment based on classification. Treatment is based on mostly Glickman's classification. Now before we go into the topic proper, let me tell you few points which are very important. Furcation involvement occurs when we cannot stop the progress of periodontal disease. You know, it starts with gingivitis, then it will progress to periodontitis. Periodontitis leads to bone loss. When the bone loss reaches furcation area, that leads to furcation involvement. That is number one. Now number two, furcation, as you know, I think you must have studied in your BDS second year when we talk about anatomy of the tooth. Furcation is a complex morphology. It's the area of complex morphology. So it is very difficult to instrument. Number three, once furcation is involved, the tooth is considered to have advanced periodontitis. And number four, the fourth point, furcation involvement presents diagnostic, prognostic, as well as treatment dilemma, even for an experienced periodontist. Now can you hear me please? Will you please write it? Am I audible? Arjun, will you please inform me? Will you please write? Okay, fine. Then let's go to now definition first. Now furcation involvement refers to the invasion of the bifurcation or trifurcation areas of multirooted teeth by periodontal disease. So what is furcation involvement? It is the invasion of bifurcation or trifurcation area of the multirooted teeth by, let's say, periodontitis. There are other causes also, but basically furcation involvement occurs because of periodontal disease. So the definition is based on that. Now next, what are the causes of furcation involvement? The primary cause of furcation involvement is marginal periodontitis, which is brought about by dental plaque. And the next cause of furcation involvement is endodontic origin. When there is endodontic problem in a tooth, you will find lesion in the furcation area. And the third one is TFO. Because of TFO also there can be furcation involvement. Now going to the classification now. We will be discussing 3 different classifications. The most important one which is applied is the Glickman's furcation involvement. Glickman has classified this into different grades. Grade 1, grade 2, grade 3 and grade 4. Now another classification that we will be discussing will be given by Hemp, Nyman and Linde. Then other classification that we will be discussing will be Tarnow and Fletcher classification. So let's start with Glickman's classification. It is on the basis of grades. Grade 1, 2, 3 and 4. Now what is grade 1 furcation involvement? Grade 1 furcation involvement, it has incipient or early lesion. It is not usually seen in the radiograph. There will be suprabony pocket and there is no horizontal component of bone loss. That means this classification, this grade 1 furcation involvement is very difficult to diagnose. Just when the bone loss reaches the furcation area, then we call it grade 1 furcation involvement. So it is not seen in the radiograph. It is very difficult to detect. Diagnosis is very difficult. This is how it looks in the radiograph. Sorry, in the figure. So this is furcation area. So bone loss, there is no horizontal component in this area. That means there is no buccolingual loss of bone. Just the bone loss has reached the furcation area. Now what is grade 2? Grade 2 furcation involvement is, it has cul-de-sac defect. Means the passage is blocked one way. That means it is like this. It is like a pocket where there is blunt. Means one side there is bone loss, other side the bone is intact. So this is grade 2 furcation involvement. Bone loss will be like this. Now what are the other features? There is definite loss of horizontal bone. Vertical bone loss may be present. And usually it is not seen in the radiograph unless it is advanced grade 2. If it is advanced grade 2 furcation defect, then we may see in the radiograph, otherwise it is not seen. This is grade 2 furcation involvement. Now what is grade 3? Grade 3 furcation involvement, in this bone is not attached to the dome of furcation. That means there is bone loss from buccal to lingual. There is bone loss. Defect may be filled with soft tissue, but we cannot see the furcation area. It is filled by soft tissue. And there is reducent in the cross of the furcation, means cross of the tooth. That means we can see in the radiograph. Grade 3 can be seen in the radiograph, which will be seen reducent area in the furcation area. Now this is grade 3. So soft tissue will be there covering the furcation area, but there is bone loss, through and through bone loss. Now what is grade 4? Now just see the difference between grade 3 and grade 4 furcation defect. In grade 4, of course it is like grade 3. There is no bone in the furcation area. Interradicular bone will be destroyed totally. There is soft tissue, there will be soft tissue recession and furcation defect will be seen clinically. Means furcation defect. In 3 we were not able to see the furcation defect. But here in grade 4 we can see the furcation defect. which is visible clinically. And there is tunnel-like through and through defect in the bifurcation area. So just the difference between 3 and 4 is there will be coverage of the bifurcation area with the soft tissue in grade 3, and it is clinically visible in grade 4. So I have kept a few slides here, that same slide, grade 1, grade 2, grade 3 and grade 4. This is grade 1, 2, 3 and 4. That same pictures I have just kept as one slide. Now, this is all about Glickman's bifurcation classification from grade 1 to grade 4. Now we will move to another classification which is equally important. This is given by Hamp, Nyman and Linde classification. Somewhere you may find just Hamp et al. Classification. Hamp et al. Means H-A-M-P, Hamp et al. Classification. So it may be written like this. So Hamp, Nyman and Linde classification, it was given in 1975. They have based this classification on the horizontal component of bone loss, means from buccal to distal, buccal to lingual, how much bone loss is there, till what extent it is lost. So they have divided it into degree 1, degree 2 and degree 3. Now what is degree 1 bifurcation involvement according to Hamp et al.? It is horizontal bone loss not exceeding 1/3 the width of the tooth. Now, how will you measure the width of the tooth? We measure the width of the tooth on the occlusal surface from buccal to lingual. Suppose if it is 9 mm, suppose from buccal to lingual, the width is 9 mm. So what we do is, we see, suppose if the probe goes till 3 mm, from buccal side or from the lingual side, either way. If it is 3 mm, till 3 mm, if the occlusal surface is 9 mm, the length of the crown, the occlusal surface, then it comes under degree 1. That means it is not exceeding 1/3 the width of the tooth. 9 mm, 1/3 is 3 mm. So it is not exceeding. So 3 mm till 3 mm, it is degree 1. It's not exactly, I am just giving you the example. Now degree 2 is horizontal bone loss exceeding 1/3 the width of the tooth, but not encompassing the entire width of the tooth. Means it is not through and through. Some bone is still left in between the interradicular area. Now, what is degree 3? Degree 3 means horizontal, through and through destruction of the periodontal tissue in bifurcation area. Okay. Now I am getting some message also. Sir, will you please change the slide? It is not changing automatically. I am just clicking on the slide. So whichever slide we need, I am just clicking that slide. Now, degree 3 is horizontal through and through defect in the bifurcation area. Now this is all about Hamp et al. Classification. Now going to another classification given by Tarnow and Fletcher. They have based this classification on the vertical component of bone loss. That means from bifurcation defect, roof of bifurcation till the base of the defect, how much bone loss is there. So that we are going to see. So they have subclassified it into subgroup A, subgroup B and subgroup C. Subgroup A means 0 to 3 mm from bifurcation, this roof of bifurcation till the base of the defect, vertical bone loss. If it is till 3 mm, it is subgroup A. Till 7 mm, 4 to 7 mm, subgroup B. Till above 7 mm, it is subgroup C. So this is all about classification. Now one thing I just wanted to tell you, here we can combine all these different classifications also together and say exactly how much bone loss is there in the bifurcation area. Suppose if I say Glickman's grade 2 uh, degree 1, that is given by Hemp et al. Degree 1 subgroup A classification of Ferguson involvement. If I say Glickman's grade 2 degree 1 subgroup A classification of Ferguson involvement means what? That means even there is a vertical component of bone loss which is not exceeding 3 mm, and degree 2 Hemp et al. Classification, that means degree 1, that means it is not exceeding 1/3 the width of the tooth, and it is of course Glickman's grade 2 Ferguson involvement. So exactly we can say how much bone loss is there, vertical or horizontal also. This way we can combine also. Now, this is all about different classifications of Ferguson involvement. Now let's go to different factors that affect Ferguson involvement. Am I audible, please? Will you please tell me, am I still audible to you all? Okay, now we will go to tooth anatomic factors affecting Ferguson involvement. There are mixed factors which affects Ferguson involvement. Number 1 is root trunk length. Number 2, root length. Number 3, root form. 4, interradicular dimension. 5th, anatomy of the Ferguson. 6th, cervical enamel projections. Now one thing here, let me just tell you, maybe you must have forgotten, root trunk length. From CEJ till this Ferguson, start of the Ferguson, that means roof of Ferguson, that length from CEJ till the Ferguson area, that portion of the root or the portion of the tooth is called as root trunk. So root trunk length means from CEJ till the roof of Ferguson. That is the length of root trunk. Then automatically root length we know from Ferguson area till the apex of the root. Now so these 6 factors we will discuss one by one. Very, very important factors. First one, root trunk length. Now we said what is root trunk. Shorter the root trunk, less attachment loss before Ferguson involvement. Please give a thought to it. Root trunk length means if it is very short, that means it is very close to the Ferguson. So even if there is very less attachment loss, it will involve Ferguson. So shorter the root trunk, less attachment loss before Ferguson involvement. But what is the advantage of this Ferguson? Where there is short root trunk, it is more accessible for maintenance. Means we can maintain it. We can do scaling and root planing, use all different types of instruments very easily. Because it is very, close to our, which is accessible. So shorter the root trunk, less attachment loss before Ferguson involvement, and more accessible for maintenance. It is wherever there is less root trunk, root trunk length is very less, it is easy to maintain. And vice versa. That means longer the root trunk, more attachment loss before Ferguson involvement, and it is very difficult to maintain it. So this is how it goes. This is the factor. How the root trunk length affects the Ferguson. Now next. Root length. It is almost same. If there is a long root trunk, there will be short roots. Short root trunk, there will be long roots. Now teeth with long roots and short trunks are more amenable to treatment since sufficient attachment remains. I think you can understand very well. That means longer the root, that means there is more bone still present around the roots. And it is easy to maintain also. because the root trunk is very short. But teeth with long root trunks and short roots are already weakened by the time furcation is involved. That means long root trunks, they will have short roots. And when there is furcation involvement in this type of teeth, already the teeth is already weakened by the time furcation is involved. So this is how it affects furcation. Now, root form means it can be fluted also, it can be curved. So why I have taken this more the curvature, less amenable to treatment? Because we have many of the teeth with furcation involvement, they have to go for endoperio lesion, or we have to do endodontic treatment. If the teeth roots, they have curved roots, so it is difficult to instrument. So this is one thing. Now another one, fourth one is interradicular dimension, is the degree of separation of the root. Interradicular dimension means how much space is there in between two roots. Wider the distance between the roots, better access for treatment and maintenance. That means if the degree of separation of the root is quite wide, it is very easy to instrument. But if they are very close together, it's very difficult to instrument those areas. And we need to have very small instruments. And I already told you this, the area of furcation is they have a complex morphology. So it is difficult to instrument. So interradicular dimension is very important when we treat furcation involvement. Now the fifth one, anatomy of furcation. In the furcation area, in the dome of furcation, you will find there can be bifurcational ridges, concavity, like this concave surface in the dome, and there can be accessory canals, which all complicate treatment and maintenance. Now, finally, cervical enamel projections. I think you must be knowing what is cervical enamel projections. They are projections of enamel into the cementum. Sometimes they can even, intrude inside the furcation area. So these cervical enamel projections, they complicate scaling and root planing. They will disturb us as well as they will disturb the patient during maintenance. Now, this cervical enamel projections, Masters and Hoskins, they have classified this into three different types based on grade. Grade 1, CEP, that means cervical enamel projection extends towards furcation. Grade 2, cervical enamel projection approaches entrance of furcation. Grade 3, cervical enamel projection actually extends into the furcation horizontally. Now, these cervical enamel projections, we can do odontoplasty. Means we can remove these with the help of rotating instruments, and that will come in the treatment section. Now, finally, now we are coming to the treatment portion. Now, we will base this treatment on Glickman's classification. Grade 1 furcation involvement. What is the treatment? Now, grade 1 furcation involvement, we can treat with scaling and root planing. But before that, we have to give thorough oral hygiene instruction to the patient. Then suppose if we reflect the flap, then we can do, remove overhanging restorations. We can remove facial grooves. We can remove CEPs, that means cervical enamel projections, either by odontoplasty or osteoplasty. So we can do osteoplasty also in that area. So odontoplasty, osteoplasty. When you read Linde, there you will see they have mentioned bifurcation plasty. So we can interchangeably use if both are used. Suppose odontoplasty and osteoplasty. Odontoplasty means we remove the cervical enamel projection, this bifurcational ridges, all this. When we remove, we call it odontoplasty. Now osteoplasty means even we can contour the bone also in that area, in the bifurcation area. Now, so these both the terms together is also known as bifurcation plasty. Please write it. Now, for grade 1 bifurcation involvement, what we do? Basically, it is scaling and root planing. Nothing more than that. But still, if we want to go still further, we can elevate a flap, full thickness flap, and then go for removal of facial grooves, CEPs, or remove some amount of bone also. Now what is grade 2 bifurcation involvement and how it is treated? Grade 2 bifurcation involvement means cul-de-sac defect, means it is not through and through. So what we can do? You can just give a thought. We can do scaling and root planing, of course. First treatment is scaling and root planing. We can go for flap surgery and do again like grade 1 osteoplasty and odontoplasty. And we can go for bone grafting with and without GTR. We can graft that area also, because one side it is closed. We can put graft in that defect and close it either with GTR, guided tissue regeneration, some membrane. We can just cover it, or without membrane also we can just cover with the flap and leave it. So we can do bone grafting also. And we can do tunnel preparation. Tunnel preparation, I just wanted to tell you here a little bit more. What is tunnel preparation? Tunnel preparation means doing osteoplasty and odontoplasty and making it grade 4. Making a tunnel through and through. Whatever bone is left, that also we will remove it. And make it through and through, so that it is maintainable by the patient. So what we use to clean that area? Which brush do we use? We use Proxa brush, interdental brush in that area. So we can do tunnel preparation also. And if it is advanced grade 2, we can go for root resection or hemisection also. Root resection for both upper and lower molars, or hemisection for lower mandibular molars. We can do that also. Now, in cases of advanced grade 2, we can go for tunnel preparation. We can go for root resection or hemisection. Now, this is, this is one of my favorite questions in the exam. Okay, tell the different options, treatment options for grade 2 bifurcation involvement. Not only mine. I have seen many of the externals, they ask this question very frequently. So please be prepared. So there are 5-6 different options for grade 2 bifurcation involvement. Now, what is the treatment for grade 3? Now, grade 3 and 4 bifurcation involvement, we will cover it together. As such, patients, here it is written non-surgical treatment. That means scaling and root planing is commonly ineffective as instrumentation is badly compromised in these areas. But we can't help it. In our part of the world, most of the patients, they don't want to go for surgical therapy. So what we need to do is, we can just do scaling and root planing and maintain that area. So that also will, save the tooth for years together. I have seen that. So we can do scaling and root planing and tell the patient how to maintain that area. Number 1 is, let's say, scaling and root planing. Now, number 2, which is more appropriate, is apically displaced flap with resective osseous surgery. We can, suppose if it is grade 3, we can do apically displaced flap and make the bifurcation visible so that patient can maintain it. So we can do apically displaced flap so that the bifurcation is visible and patient can maintain it. We can do that by resective osseous surgery. Now, of course, maybe somewhere it is written, we can go for bone regeneration also in this area if vertical defect is there. But most of the time it is ineffective. Now, why do we go for apically displaced flap? So that we can maintain the self-cleansing area in that tooth. So we can give proxa brush or tell the patient to maintain it. We have some floss also. Floss which we can enter from one side and just, there are super floss where, we can just enter the furcation area and then just, like a massaging, we can just clean that area. That also we can do. Now, the other options, treatment options for grade 3 and for furcation is, we can go for root resection, means removal of one of the roots, or it is also known as root amputation. Now, other option is hemisection, means we can, furcation is involved, we can just bifurcate the tooth. We can just split the tooth into two parts. So that is called hemisection or bicuspidization or bisection, or it is also known as separation also. So some of the examiners who are little bit old, you may get confused. So this hemisection and bicuspidization, I'm just telling you, maybe in your book I have seen hemisection and bicuspidization. It is after all same thing as per your book. But when we studied that time, hemisection and bicuspidization was different. So hemisection means splitting the tooth and removing one of the roots with the crown. That was hemisection in our time. But bicuspidization means splitting the tooth and keeping both the roots together. Means like bicuspids, like premolars. We can keep two teeth. Okay, bicuspidization. So that was the difference. But as per our book, it is same thing. But whatever sir has taught us, hemisection means removal of one of the, just bifurcating it, cutting into two parts, crown with the roots, and removing one of the root is hemisection. Bicuspidization means keeping both the roots there. It is also known as bisection or separation also. Somewhere it is mentioned separation. Now, one more treatment option for furcation involvement is extraction. Suppose if we cannot do anything, if our scaling and root planing is not helpful, if the patient is not ready for other treatment options, then we can go for extraction. So that is one last option for grade 3 and grade 4 furcation involvement. Now, let's see what is root resection. Now, root resection, this is how it looks. Suppose if it is upper molar, we can remove one of the roots. This is called root resection or amputation, root amputation. So it will be like this. When you remove one of the roots, it will be like this, only two rooted upper molars. So this we can do even for lower molars also. We can remove one of the roots. So with one root, this tooth is there. So we have removed one of the roots. So this can be done even for mandibular molars also, root resection. Okay. Now what are the indications for root resection or root amputation? Where we need to do this? We need to do root amputation or root resection in teeth of critical importance. Suppose that tooth is acting as an abutment and we need to save it somehow. Then we need to go for root resection. After that, save the tooth. So, teeth of critical importance, there only we go for root resection. Now, another indication is teeth with sufficient attachment remaining with advanced bone loss in one of the roots. Suppose two roots, one there is advanced bone loss, another root bone is still remaining, enough bone is there to support the tooth, then there also we can go for root resection. One of the roots we can remove it. Now, teeth for which no other treatment is effective. Suppose articulated tooth, molar, suppose one root is gone, fractured, or there is, suppose file is, fractured, it's difficult to remove, there is some lesion in the apex, then in that case, teeth for which no other treatment is effective, there also articulated tooth with root fracture or any instrument fracture, that also we can remove with root resection. And what type of patient should be there for root resection? Patients with good oral hygiene and less caries activity are the ideal candidate for root resection. Okay, I have just put this in not red, but this is I think pink. Now resected teeth require endodontic treatment and casted restoration. Meaning what? It needs sizable financial investment to save the tooth. Resected teeth require endodontic treatment and cast restoration. Therefore, it needs sizable financial investment on the part of the patient. Now, can you tell me what is the other alternative? Of course, implant. Maybe with this money, we can go for implant therapy. So nowadays, many of the teeth are extracted and they go for implant therapy. Now, what are the guidelines to determine which root to remove or which root to resect? Guidelines to determine which root to remove. Now, remove the root or resect the root that will eliminate the furcation and allow maintainable architecture of remaining roots. So what is the first one? Remove the root that will eliminate the furcation and allow maintainable architecture of remaining roots. Now, number 2, remove the root with the greatest amount of attachment loss and bone destruction. Wherever there is huge amount of bone loss and the other root is still intact. So in that case, we remove the root which has huge amount of bone loss. Now, remove the root, third one, remove the root that best contributes to elimination of periodontal problems on adjacent teeth. So even if there is bone loss in the adjacent teeth, so that to prevent it, it is best to remove the root which is close to the adjacent teeth, which is causing problem even in the adjacent teeth. Now, fourth one, remove the root or resect the root with the greatest number of anatomic problems. Example, dilaceration, developmental groups, accessory canals. So, remove that root, headache is gone. For RCT or even for odontoplasty, the headache is gone. So, remove the root with the greatest number of anatomic problems. Now, that's all for root resection. Now, let's almost ending the slide. Now, finally, hemisection or bicuspidization. This is how it looks. This is hemisection as per what we studied. So what we did, we splitted the tooth and removed the crown along with the roots. So this is hemisection. Bicuspidization means what we do, we just, bisect it and keep both the teeth. Both the splitted part. So that is bicuspidization. Okay, I think this is the last slide. Now, before we conclude, let's just revise it once. Now, first you should know the definition. Let's go back to the learning objectives. You should know the definition. Definition says, furcation involvement refers to invasion of furcation and trifurcation, bifurcation or trifurcation areas of the multi-rooted teeth by periodontal disease. That is the definition of furcation involvement. Then when we come to causes, number one cause of furcation involvement is periodontal disease. Of course, your bacterial plaque leading to inflammation, then gingivitis, periodontitis. Periodontitis automatically leads to bone loss, involves the furcation area, so causing furcation involvement. Then the cause of furcation involvement is also endodontic problem. Teeth with endodontic problem also have furcation involvement. Then trauma from occlusion also causes furcation involvement. Now there are different classifications. The most important classification is Glickman's classification, given in 1953, and he has classified under grade 1, grade 2, grade 3 and grade 4. Now grade 1 is incipient lesion, which is very difficult to diagnose also. Now grade 2 is there is a cul-de-sac defect, and advanced grade 2 only we can see in the radiograph. And grade 3 means, of course, there is bone loss, through and through bone loss, but which is not seen clinically. Furcation area is not seen clinically because there is soft tissue in the furcation area. Grade 4, of course, it's like grade 3. There is through and through bone loss, but the soft tissue gets receded and the furcation area becomes visible. And then according to Ham et al. Or Ham, Nyman and Linde classification, it is based on horizontal component of bone loss. They have classified this under degree 1, degree 2 and degree 3 classification. Now this degree 1 means the horizontal component of bone loss not exceeding 1/3 the width of the tooth. Degree 2 means more than 1/3 but not encompassing the whole length of the buccolingual, that bone loss. Now degree 3 means there is through and through bone loss. Now according to Tarnow and Fletcher, they have classified it into vertical, based on vertical component, subgroup A, subgroup B and subgroup C, 1 to 3 mm, then 4 to 7 mm and above 7 mm. They have classified based on vertical component of bone loss. Now there are different factors on which this furcation involvement depends. First one is your root trunk length, then root length of the root, then comes your root form, then interradicular dimension, that means this degree of separation of the roots, then anatomy of furcation, if there are some ridges or concavity in the dome of furcation. Then finally the last factor is CEP, that means cervical enamel projections, if they are present. That also affects our SRP as well as maintenance by the patient. Now then when we go to treatment, grade 1 furcation treatment is your scaling and root planing. Then we can do furcation plasty also if it is needed. Grade 2, there are different treatment options. First we can go for scaling and root planing, then we can do flap surgery, and along with the flap surgery we can do furcation plasty. We can again go for degree 2 is very conducive for grafting. We can do grafting, graft with or without GTR we can do. We can go for tunneling also. Tunneling means making through and through, and which can be easy for the patient to maintain it, like making it like grade 4. Then finally we can either go for root resection also, hemisection also for grade 2. Grade 3 and 4, again, if patient is not ready for sophisticated treatment, we can do scaling and root planing. We can go for I mean, like making it like grade 4, 3 into grade 4, and easy for the patient to maintain it. And we will tell the patient to maintain that area with the help of proxa brush or interdental brush. Every time he brushes, he can use that before starting his brushing. Then we can go for root resection, hemisection, and finally we can go for extraction if nothing works. So that's all about furcation involvement. I hope you must have understood. If anything is there which is not understood, we can still discuss in the department. Here we are not able to write anything, make a figure to make you understand. So I think that ends our class. Thank you so much. Okay. How was the class? Will you please give me your attendance? Whatever it has come here, I think this is attendance, isn't it? Whoever name is here, okay. I think they are present. This is also this is my first experience. Something very new. Okay, many are there. I am very happy. Okay, I am seeing many names. I am just scrolling over the names. Okay, thank you so much. Okay, then stay safe. Bye. I am stopping the presentation. So if you have any question, you can ask. I think still we have some more minutes left. Minutes left. Okay, I am seeing. Okay, Dheeraj, Mega. Okay, okay. No question then, shall we? Okay, thank you so much. So many people have written. Thank you, sir. Thank you, sir. Thank you. All of you, thank you so much. This is a new experience for me. Okay, bye. I'm the presentation. Bye.